Okay, we'll go ahead and get started as other people continue to join. First of all, on behalf of Ocumetics, I just want to thank everyone for taking time out of your busy schedule to join in with us to talk about a historical update to the journey to FDA with the Ocumetics technology. For those of you who I have not had the pleasure of meeting, my name is Dean Burns, President and CEO of Ocumetics, and I am just delighted to provide you guys with an update as to what's been going on. Not only is it a historic time for us by hitting one of the major milestones that we had in front of us, which is our first in human study. It's a historical milestone because there are only a few companies now in this space that are in human trials. And I'll show you a competitive slide of the companies that are there, but there are 14 companies that are all trying to come up with an accommodative lens technology. There's only 6 of us that are in some form of human trials, and some are in second versions of their in-human trials. So we're just excited and happy to be a part of that. By way of an agenda, these are the 4 things that I really want to cover. And then towards the end, we will spend time with a Q&A. I always like to start things with what is the problem that we're trying to solve and what are the potential solutions that allow us to get there. I'm going to give you a major milestone update, which is part of the journey that we all have been on. And for those of you who have been with us since day one, thank you so much for sticking with us. It hasn't been easy to get to this point, but we're here and we're celebrating. But we know that we have a lot of work left to do. So we'll talk a little bit about what that milestone is. I have been flooded with emails from a lot of people with 2 basic questions. One, what is a FIH study? So that's first in human is what FIH stands for. What is the study? What does that entail? And can I get involved in that? So we'll spend a little bit of time just talking about that. And then I'll walk you through what's next for us, because we have a laundry list of things that we need to accomplish and get done. We're not resting on this particular milestone because there are 2 or 3 other big milestones that we have to hit. And then what I want to do is I want to make sure that I leave enough time to answer any and all questions that you may have. You may ask me a question that is somewhat controversial. And what I mean by that is if it is material and financial and it crosses the line of insider trading, I won't answer. The other thing is if we get into an area of FDA regulatory compliance that I'm not comfortable with, I won't answer that question either. And I'll tell you. And I may even direct it and try to come up with a different question with a different answer that will help you out. But I want to leave enough time towards the end to really talk about everything that's on your mind and answer those questions. So let's just start off with what the problem is. The problem is simply, as we age, your eye will deteriorate or your vision will deteriorate. Nobody gets a pass on this. That's been a big question that I've gotten for the last 2 weeks. Am I excluded from getting a cataract or entering into a presbyopic type condition? And the answer is no, it's part of aging. We all pass through that. How do you know whether or not you're a presbyo? Well, first of all, presbyopia is basically the loss of accommodation. And the lens that we are creating is what we call an accommodating IOL. And I'll showcase that in a few other slides. But basically, you lose the ability to see in the distance, intermediate, and near automatically as you age. And what goes first is your near vision. So you'll notice that the book or the reading card or the document or your phone that you've been looking at, you start to push it out a little further to make it a little more clear. And then it gets to the point where your reading distance is past basically your arm. So then you have to go into cheaters. And those are the glasses that you can pick up at any big box retail store. And they start off kind of in that minus plus range of 75, and it goes all the way up to +3. So depending on your condition and your age, we'll all end up with some level of reading glasses. And it actually starts around 45, maybe 50 years of age. But once you get past that, then you enter into an area that we call cataract disease. And it's that same lens that has become inflexible. It's now becoming cloudy. And so that's the natural crystalline lens in the eye. And that's a clinical term that I'm going to refer to as we go through the presentation. So I'll try not to geek out on technology or clinical stuff, but the crystalline lens is the organ in the eye or part of the organ that's in the eye that goes bad. And when that goes bad, we have to replace it with a prosthetic IOL. And that is a one-time condition. It's a one-time surgery. You don't really have to have it done again. That procedure takes maybe 20, 30 minutes to do. We do it in both eyes, not at the same time, one after the other. But it is something that we have to do to correct cataract disease. If you leave it untreated, you will go blind. So there are places around the world, because they don't have access to this type of technology, that people go blind from the lack of cataract surgery. Here in the US, we don't have that condition because we have all these technologies and the ability to pay for the surgery to get it done. So let's talk about how we fix the problem today. This is an example of an IOL that has been implanted in this patient's eyes. And inside the round circle that I actually have up on the screen, you see these annular rings. Those annular rings are rings that allow light to come into the eye and get split into different focal points, which gives the patient, if this was a bifocal lens, it gives the patient to see in the distance and near. If it's a trifocal intraocular lens, it would give the patient the ability to see in the distance, intermediate, and near. So many of you should be saying, okay, well, that doesn't sound too bad. I'd like to have that. Well, here's what comes with that. With that type of technology, and it's the best we have today, you have nighttime visual disturbance issues. So on the right-hand side of this slide is a glare pattern based on the light source that we look at. So if you're looking at street lights, you may see ghosting or halos. If you look at oncoming cars, you may get what's called a glare. And in some cases, you'll get glare and starburst at the same time. The problem with that is it's very debilitating. Now, I have had cataract surgery, and the lens that I have in is the one that is depicted in my example here. And I had every one of these conditions for about 18 months. I couldn't drive at nighttime. My wife had to drive me around. So I am a firsthand patient, knowing that you have nighttime visual disturbances, even with the best technology currently available. So what are we trying to do? Well, we're trying to create an IOL that gives you not only daytime clarity, but also nighttime clarity. And this is what we want patients to be able to see at nighttime. Very clear images, a tremendous amount of detail that they should be able to see with the right technology. So let me take you through what the Ocumetics technology and what our design criteria is. We came up with a solution that allows us to replace the natural crystalline lens with a technology that mimics what we refer to as the biokinetics of the eye. And what biokinetics really means, without geeking out on technology, is it means the mechanics of the eye, which include the muscles and the attachments, working with the clear lens technology so we can let the light rays come through the eye and be casted upon the retina, and then have that information transmitted to the brain so the brain can come back and say, oh, you're looking at a door. Oh, you're looking at your daughter. Oh, you're looking at a road, and make that all happen without you having to think about it. We wanted to make sure that we had a technology that eliminated post-surgical side effects. I just showed you 5 post-surgical side effects just with night driving or night vision. And that was one of our goals. We wanted to make sure that we eliminated that. We wanted a high quality optic so that your vision in the daytime was as clear as your vision at nighttime. And then the final criteria is we wanted to make sure that things would be designed where that technology will be affordable for everybody to take advantage of. And before we even get to the end of this presentation, do not ask me how much this is. I'm going to point you to what the current pricing is for premium IOLs, because I'm not allowed to talk about pricing on this call. So if you ask that question, I'm going to give you the pricing of today's technology. Okay, so let's talk about accommodation. I just told you accommodation or presbyopia is the inability to accommodate. What is accommodation? I hope that you guys can see my pointer, but as you look in the distance, we have a this is a picture out of a textbook actually. Inside your eye, and this is a cross section, you have your crystalline lens, which is this structure inside where my pointer is, if you can see my pointer. It's suspended in the eye in a bag. It's a clear bag. Attached to the bag are these yellow finger-like attachments on my slide. We call those the zonules. Those attached to the bag, and attached to the zonules in the slide is a pinkish red thing. That is a muscle. We call that the ciliary muscle. That muscle gets activated, pulling on the zonules, which then pull on the bag. And when it does that, it actually squeezes that lens down, and that lens becomes very thin. And you can see in my picture here that the picture on the left-hand side is thinner than the picture on the right-hand side. When we thin out the lens, it allows us to see in the distance. When we want to see intermediate and up close, what we have to do is we have to relax that lens, relax the zonules, so the lens can get larger. And that is controlled by basically the brain and the stimulus that's coming into the eye. And you don't think about it until you have lost accommodation. So what does that mean in terms of technology? Well, Dr. Webb came up with this ingenious IOL complex that actually mimics exactly what the normal eye does. The way we do that is we have a dual optic system that we implant in that bag, that same space where that crystalline lens was. And when the two optics come together, that allows us to see in the distance. When the two optics spread apart, which is in the right-hand side of this, that allows us to see intermediate and up close. So if we want to see in the distance, in this case, we're just driving down a road looking into infinity. We have a clear vision of the road and the scenery around us with this optic. And if we want to see up close or intermediate, which is either looking at your dash or possibly looking at your phone, we can do that by the two optics coming apart from each other. And this is what we call biokinetics, and we mimic exactly what the normal eye does. So what is the milestone that we achieve? Well, we call it the CAR in our first in-human study. And the milestone was we inserted the IOL that I just showed you in patients on August the 15th. And this was a major, major, major accomplishment for Ocumetics. And it's actually a fantastic accomplishment for everyone who's participating in this part of eye care, because this is the technology that everybody has been waiting for. It's kind of considered the holy grail of eye lens implantation. And so we are now one of five companies that have actually implanted this lens in a human type study. To give you a quick update on the patients are recovering everything. The surgery was very positive. The patients were extremely happy. Everybody's recovering well. 1 week after surgery, there's still no complications reported. And our lens technology has satisfied certain safety hurdles that we were looking at, so much so that the hospital and the surgeon have started working on our second surgical day, and they've started recruiting patients for the next implantation of this technology. So things are going really well. I don't get a chance that often because of the distance with my team, but I want to publicly recognize my team for this historical period of time. The team's dedication and the innovation that has come out of this group is second to none. We value collaboration. We fight like brothers and sisters, but at the end of the day, we always put the patient first. And we look at it as what's more important, the patient. What's after that? The doctor. What's after that? The facility. What's after that? Ocumetics. So we put a lot of things in front of us to make sure that we do the right thing each and every time, each and every day. And so I just want to publicly recognize my team of scientists and engineers, the doctors that we work with, the advisors that help steer us in a certain direction, and certainly you guys for believing in us and investing in the organization to help us get to this particular point in time. So I applaud this entire group for getting us to this point. All right. So what is expected from a first-in-human study? I have actually gotten so many emails from this. I decided to do 2 slides just to try to level set everyone. So when you start looking at technology like this, the journey to FDA approval is a very long process. Some people have said, why does it take so long? Well, it's not like you're digging a hole or cutting down a tree. You're putting something that is considered foreign into the human body, and you want to make sure that whatever that thing is, that it performs each and every time it goes in. So imagine yourself having this surgery done, and you wake up in the morning, you want to see everything. So we have to be very meticulous about how we put it in, how the technology works, what changes we make. And so there's a lot of stuff that goes into the journey to FDA approval. It all starts with biocompatibility. That is the study that we had to do to show safety with this lens. It's a 6-month process just to do that study. And we do that with animals. In our particular case in ophthalmology, we use New Zealand rabbits. Now, before you ask me why New Zealand rabbits, I'm going to ask you to look at your thumb on your left-hand side, so your left hand, and look at your pinky finger on your right-hand side. Bring those two together and look at the difference in size of your nail. The New Zealand rabbit is the larger thumbnail, where the smaller pinky nail is the size of the eye that you'll find with bunny rabbits at the pet store. We can't do surgery on a pinky nail eye. We have to have the really large eye, which is very close to the human eye. So we buy special purpose bunnies, rabbits from New Zealand. In this particular case, we had 6 to 10 rabbits in the biocompatibility study. We did not name them because we were told that that is taboo. for any study. You don't want to get too close to them. So we didn't name the bunnies, but we did extremely, extremely, extremely well in biocompatibility. And I'll make one note that if you go through biocompatibility and you fail, there's not a snowball's chance in hell that you're actually going to get an FDA approval on your technology unless you change it. So we did extremely well, and we compared ourselves with a control lens that is commercially available, and we did really well. So that's the first major milestone. The second one is first in human. First in human is a proof of concept or proof of design study. It usually takes 12 to 18 months, depending on how many subjects you enroll in your study, to get through that process. And in our particular case, we have a protocol that allows us to do up to 30 patients or subjects for first in human. That information is actually used with the application that goes to the FDA for the last part of this, which is the FDA study, and that's the proof of performance study. That's a 36-month study with over 350 to 400 patients that will be enrolled in that study. That is what is used to get an FDA approval so that you can commercialize this technology. And there are some things that you can do to commercialize early, but for the most part, that's a 3-year study. And the 3 years is a culmination of all the tests and the endpoints that we have to actually demonstrate and show to the FDA to get consideration, to get an approval to commercialize the lens. So what's a protocol? Well, a protocol is basically a well-established group of strict guidelines or procedures on how we're going to handle the patients and how we're going to do the surgery. Once we agree to what that protocol is, we very seldom change it because it's a really strict document that has to go through a lot of hands and a lot of approvals to actually get it done. Our objective with the lens going into the first in human study was to basically design technology that allows us to restore the eye's natural ability to see far, intermediate, and distance without the patient having to think it through. Here again, we're trying to mimic what God has already given us in the ability to see at those different vision points. We also wanted to make sure that we did an excellent job with our engineering. Our biocompatibility matched that of what we saw with the bunny study, and that our number one thing that we want to make sure is that this technology is safe. The reason we have to do that is there's some legal documents that we cannot afford to engage in, which are product liability legal documents and fail-safe laws, which means that your product can fail, but it can't hurt a patient. So everything centers and pivots off of safety, which is why I have it highlighted in the slide here. So our protocol for this particular study is a 3-group study or 3-arm study with up to 30 patients. Now, when you study in these types of studies, I have to tell you, you have primary and secondary endpoints that you look at. For group 1, our primary endpoint is safety. Our secondary endpoint for group 1 is distance correction. So how well does the patient see in the distance? For group 2, the primary endpoint is safety and distance. The secondary endpoint is near correction. So now we're trying to make sure that the patient has accommodative amplitudes and they can see up close. And I'll share with you what the original patients had to say about that in just a second. And then in the third group, our primary is safety, distance, and near. And our secondary is this thing called binocular summation. So what is binocular summation? The example I can give you is a pair of binoculars. If you look at the top of the eyepieces of a pair of binoculars, you have the ability to rotate them both on a positive and a negative scale, which basically helps you with your vision correction. When you want to see one image out of a pair of binoculars, you actually squeeze them in and you go from two images to one image. And that condition or that process is what we refer to as binocular summation. And so that's the other thing that we want to study. In group 3, we will put a Ocumetics lens in both eyes and make sure that the eyes are working together and the brain can resolve one image out of the two different inputs that will be coming in from left and right. In groups 1 and 2, we will put the Ocumetics in one eye and we will put a control study lens in the other eye. And that lens is something that is commercially available that's already been approved by the FDA. So here's the money slide. If you don't remember anything else about my presentation, remember this. These individuals, and this is just two of the patients that I actually liked for my slides that I put on this. I could have chosen some others, but the first patients to be implanted with this lens are in front of you right here. And the thing I will draw your attention to is everybody is smiling. So the gentleman in the surgical scrubs is our surgeon in Mexico. These are his patients, and these patients are ecstatic. They are happy. And in fact, I had to quote one of the ladies here that said, after just, and this is her quote, it's not mine, after just one day of surgery, I can see the words and colors on the wall, and I can read the information on my makeup box. That pitch on a makeup box instruction is close to like 5 or 6 pitch. It is so tiny. And for her to even be able to say that post-op day 1 is incredible. And so we were extremely happy. Now, we can't give you numbers because we won't have numbers until 1 month after surgery. And the intervals that the patients will come in for their testing, where we push vision and take numbers, are 1 month, 3 months, 6 months, 9 months, 12 months. So those are 5 separate endpoints where we actually push vision and take the numbers that you guys are probably accustomed to, which is like 2020, 2025, 2015.5, whatever those numbers are. We do those at very specific endpoints. So what's next for Ocumetics? Well, my job just got a little harder because my timelines are moving a little faster. So I tend to do things in smaller batches so that I can keep the main thing the main thing. So the very first thing that I need to make sure that I do an exceptional job and I make sure that I move the team in a certain direction is we need to complete the first in-human studies, get all the subjects through within the next 6 to 9 months. We need to report that information through our clinical study reports to the FDA so that we can ask for permission to do the multi-center clinical trial, which is the study that will have over 350 to 400 patients in. While I'm doing that, I need to complete the next round of funding, which is a Series B round of funding. It's $25 million to get us through the entire multi-center clinical trial phase, which is a 3-year phase. At the same time, I have to ramp up manufacturing, which is one of the key things I have to focus on, because I have to do an FDA sterility study to get my indication from the FDA of how long I can put these boxes on the shelf and they stay sterile to be used in the surgery. And so that is our manufacturing age-related FDA study that we have to do. During that time, I'm giving the design team an opportunity that if the doctor or our clinical team come to us and say, hey, we need to make some changes, we have an opportunity between first in human and the multi-center trial to do what we've referred to as an optimization on the lens. So if there's some things that we can do to either improve the quality of the lens, the refraction of the lens, so that's the ability of the patient to be able to see, the handling of the lens, which is something that we will also study as part of first in human. So how easy or how hard is it for the doctor to handle it? How easy or how hard is it for us to train? That we make those optimization changes before we go into the multi-center clinical trial, because once we do our paperwork submission to the FDA and we're into the trial, we cannot change the lens. So we have to go through a hard design lockdown. And the worst time to learn is when you're in the midst of the trial. We want to make sure that we take advantage of first in human. If we learn anything, we optimize the lens so that we have the technology that we need to actually get us through the multi-center clinical trial. The other thing that I will be doing is, this is a picture of our advisory group. And these are some of the best surgeons in the world for anterior segment surgery. We call that cataract surgery, anterior segment surgery. These are corneal refractive surgeons. These are folks that handle some of the toughest cases that money can buy. And I'll be working with them a little closer to make sure that they help us steer the right way to get into our multi-center clinical trial. Some of these faces that are on this picture are some of the doctors that will be involved in the multi-center clinical trial. I used to have the institutions that they represented, but then I had people calling me saying, hey, I'm close to that institution. Can I get into the trial? So I decided just to take those things off. When we get to the point where we do the multi-center clinical trial, we'll make that announcement. So just stay close to the Ocumetics website. That's where all the latest and greatest information will be posted. Finally, we'll be working closer with the FDA. One of the things that we have learned, or at least I have learned in the number of years I've done this, for those of you who don't know me, the Ocumetics technology will be my 16th FDA approval. So I've already got 15 in the hopper. They're technologies that if I just started rattling them off, you would say, oh yeah, I know that. They're in all 4 surgical areas. So cataract, retinal, refractive, and also pharmaceuticals. And so one of the things that I've learned in the years I've been doing this is you have a good relationship with the FDA and you make them a partner. And one of the ways to make them a partner is to seek their guidance up front. So we'll be working with the FDA a little closer to make sure that they give us good guidance as we move along. I have been invited to visit with some of the names of the companies that are on this list once we get our 1-month data on our first in human patients. The invite with these companies is always a good thing, because either they look at you as a competitor or they look at you as a partner. And I would rather have a partnership relationship with these companies because they're a lot bigger than Ocumetics, and they can actually help us get to the next level as we start walking down the bigger path with the multi-center clinical trial. So I have mentioned to you that there are 6 companies that are in human trials. So these are the names of the companies that are in human trials, but there are 14 companies that are in the space. We just happen to be one of 6 that's in a human trial, and we think that we're the best. We believe that we have the best mousetrap, and only the clinical trial will actually show that. So I'm not going to sit here and bash any technology on here. I am just delighted that we have so many companies that are in this particular space And for those of you that are interested in investments, it's good to know that the largest eye care company in the world, which is Alcon, has a lens in this particular category. And I used to work for Alcon for 28 years. And when they get in, they pretty much legitimize the pool, and they have the ability to dominate if they have a technology that actually works out well. I happen to know all of these technologies, and I happen to believe, not think, but believe that our mousetrap is a better mousetrap. But here again, we'll let the clinical trials prove that out. I've gotten a lot of questions about a lot of terms that people have heard about different types of IOLs. So you'll hear monofocal lenses. Those are just distance related lenses. Sometimes they are referred to in the US government paid lenses. They're very good for distance correction, but they give you no intermediate and no near. The good thing is there are really no side effects other than maybe some indirect light coming in and you get a glare source. Other than that, they're pretty safe. EDOF is extended depth of focus. That's what that means. And it's a great distance lens. For near vision, you can get some near or maybe intermediate. You'll have to figure it out because the focal point's a little bit different. But here again, it's a really good lens because there are no side effects associated with it. When you get into the lenses that were designed to give you distance, intermediate, and near, which are the bifocals and the trifocal lenses, that's where you start having all of the side effects. So with a bifocal, you get distance and near, but you get a ton of side effects. I don't want to bash the technology, but I want to be as open and as honest as I can be. And I'm also a patient, so I know about these side effects, which is ghosting halo, starburst, glare, and some kind of light scatter. You get that both from bifocals and trifocals. Trifocals will give you distance, intermediate, and near, but yes, you're going to have the side effects to go with it. And depending on, it's called neuroadaptation, depending on your brain and how you adapt, it may take you a while to get to the point where you like your vision. It certainly took me 18 months before I could even say, I really like this vision. So then there's this last category called accommodating, which is what the 6 companies that I just showed you, which includes us, participates in. The really good thing about that category is the category or the lens designs give you near, intermediate, and distance vision with no side effects. How cool is that? And we're all implementing our technology a little bit different. I'll let the market dynamics actually play out, but it's a category that, like I said earlier, it's been referred to as the Holy Grail. This is where we really want to be. And it's a really complex lens to make, which is why it's taken so long to even get here. But this is really our moonshot. It's kind of like all these countries want to get to the moon. We all have different ways to get there, but we're going to get there. And so with this lens, we're going to get there. It's taken us a long time to even come up with a design that we could take into human trials. And those 6 companies are, including us, are in human trials. And so we're going to get there eventually. And this is the lens that you really want to have if you can get it. Last but certainly not least, I did want to share with everyone how well we're doing with our fundraising milestones and what the asks are. So all the check marks in the greens are the areas that we have raised up to today. We've raised about $10.4 million, which is really good because that got us through proof of concept all the way into first in human, and even with some of the paperwork that we need to get through the multi-center clinical trial. So MCCT it actually stands for multi-center clinical trial, and there's prep paperwork that has to be done for the FDA. Where are we going? Well, we're into our clinical phase, which is Series B which is a Series B round, and we're looking to raise 25 million US. And that 25 million US will get us through everything. It'll pay off all of our debt. It will help us with what we need to do from a manufacturing perspective and get set up to do a launch. And so we want to do that raise starting this year and kind of spilling over into 2026. But that money should carry us through to 2028 with everything that we need. And then the approval to commercialize this lens, if we stand up a company, which we would start working on that in 2029, is a $35 million US raise. And that gets us a CE mark with early commercialization. It gets us FDA approval. It gets everything that we need, including the foundation for a complete business where we would end up hiring people and truly commercializing and going after this market. So that's kind of the landscape as we know it today. For those of you who want to know really how big the market is, for the intraocular lens, it's a $4.5 billion market. The area that we're looking to enter into is the 65 plus segment, which is a $1.2 billion market. And we'll go into that market with the lens that we are pushing through first in human and ultimately through the multi-center clinical trial. We're not just a one lens company. We actually have other lens designs that we're working on that we believe would be suited for that 45-year-old group. And so we've got some other additions to the product offering that would allow us to actually play in that $1.7 billion segment as well. Finally, my closing thoughts to you guys would be, first of all, thank you, thank you, thank you. Together, we can change the lives of many people in really three ways. Number one is we can make safer, more effective implants. This is good for patients, caregivers, doctors, staff, the practice. It's just good all the way around for us to really look at designs that allow us to make it safer and more effective in the implants that we do. You know, it's been through our openness that we've been able to come up with designs that allow us to achieve an advanced vision to restore the lives of those that are dealing with these debilitating conditions. And it's a need that we all end up passing through. So nobody gets a pass on this one. You'll end up with debilitating eye conditions like cataracts, and you'll want to be able to take advantage of technology like the one that we have. And then finally, it gives us the ability to enable people to see and experience the world in a more profound and more profound way and improve the quality of life that they have. We live longer and we stay active. And so this allows us to do that. And with that, I will say thank you, thank you, thank you for being on this ride with us. But keep in mind, there's more to come. And we'll keep you up to date and provide you with as much information as we possibly can. So with that, I am going to stop sharing my screen and I'm going to go back to Sean, and Sean will take questions from this point forward.
Great stuff there, Dean. Really interesting. So hello, everyone. My name is Sean Jewett. I work with the Ocumetics marketing team. And like Dean just said, I'm just going to help read off some questions here. If you guys have any questions, just pop it in the Q&A section of your Zoom window there, and we'll try to get to everyone here. So this question is from Paul. He asks, does the Ocumetics IOL provide UV 400, aka full UVA and UVB protection?
So the short answer is yes. And the number that you just stated I don't know what that particular standard is, but in the world of ophthalmology, we actually have UV protecting materials, and we have to answer to either the ISO standard or the ANSI standard that comes down for those types of technologies. So the short answer is yes. And the specific number, I don't know what that number is offhand.
Okay. This next one is from Paul. He asks, has there been any accommodative response in the first-in-human patients?
There has been post-surgical observations. If a person can see in the distance and then turn around and see up near, one can assume that they are accommodating to actually do that, because it's not physically possible to do that if your eye is not accommodating. But we don't have the numbers because we have to let the patients heal, and we don't push vision until 1 month. And then the endpoints are 1 month, 3 months, 6 months, 9 months, and 12 months.
Okay, makes sense. Here's a question from Dayton. He asks, he says, Alcon just this month acquired Star Surgical for 1.5 billion USD. And earlier in the year, in March, they acquired Lenzar for 356 million USD. Given that about 17% of their cash flows come from their IOL portfolio, what do you think that means for Ocumetics? Also, are you in conversations, and I think you did mention this, with Alcon or other companies like Johnson & Johnson and Bausch & Lomb?
Wow, big question. So let me try to break it down, and Sean, keep me honest so that I can answer everything that he asked.
Yeah.
So if you know anything about Alcon, they're the largest eye care company in the world. Their growth has been fueled through acquisitions for the last 15, 20 years. So the homegrown organic growth, they just don't do anymore. They are cash heavy. So their ability to go out and buy anybody is unbelievable. So the Star Surgical purchase, I know a little bit about that one, does not really fit into the R&D portfolio, but they did not want to allow somebody to buy it. So their purchase of $1.5 billion was more of a blocking tactic to keep competition from getting Star Surgical. If you get an ICL put in your eye, it only helps with a patient who is fighting the difference between a lens in the eye and having LASIK. The part of the eye that is, as you get older, you hit 45, that's changing is the middle part of the eye. So just because you have an ICL in your eye doesn't mean that you won't have cataract surgery later on. The lens AR was a purchase that they needed to make because the combination laser phaco that they created did not work well. And that was my project before I left. So I know a lot about the laser phaco. So it was easier just to go buy one than to keep throwing money down. It's kind of like owning a boat. You know, at some point in time, you stop putting money in that hole. And so that's what the lens AR was. It was to fill a gap because their product that they were developing actually failed. For us, they were the first company to come to me and say, listen, when you get in and out of first in human, at least with your first 1 month patients, please come and see us. Because I know a little bit about their lens going through their in-human trials. And I won't say anything good or bad about the Power Vision lens, but we are going to be very competitive against that lens. So if they did an M&A deal, as an example, it could be a good thing for us, but only time will tell. That's not our exit strategy. We're still working on it. Um, but they would be a good strategic partner if we chose to go in that direction. Did I hit all the parts, Sean?
I think the only thing maybe is other companies like Johnson and Johnson and Bosch and Lomb.
Oh yeah. So I've been invited to go to Alcon in basically a month or so. I've been invited to go talk to Zeiss out in California. I've been invited to go visit with BNL in St. Louis. And Rayner has said, hey, we want to sit down and talk with you as well. And they're out in California. It's just a matter of if I do a California trip, can I do two companies at the same time? J&J is the only group that's kind of on the fence. But if you know anything about J&J, they're still in flux because they're changing leadership at the C level. So the C-suite's changing. Aaron Schauhorn, who was my mentee at Alcon, is now over that group. And she's still trying to get her feet up under for that group. So they're the only ones that I've actually talked with J&J, but they did not extend an invite to come and see him.
Okay. Very exciting stuff. Okay. Maybe a little shorter questions here. This one's from Tom. He asks, how do you become a test subject for the next set of clinical trials?
Okay, so I get that question quite often. The way you get inducted into a trial is twofold. Number one, uh, the trial location has to be in an area where you can adhere to whatever the schedule is. So the 1 day post visit, the 1 week post visit, I mean, you have to be in an area where you can be a part of that because the trial cannot afford to lose you to what's called follow-up. So the way you get involved is if you hear about a trial that's in an area where you are, you actually contact that doctor's office that would be announced as part of the trial and ask them if you could come in for a free evaluation to see if you would be a candidate for the trial. Ocumetics doesn't have the ability or the authority to say that a person can be a patient in a trial because we're not the ones that are going to do the exam and look at the inclusion exclusion criteria to see if you would be a candidate for the trial. It's actually the practice. What we do is we name the practice. So if this was California, Los Angeles, we could put on the website Dr. Dean Burns, me, in Los Angeles, California, has been named one of the doctors to participate in the accommodative lens trial. If you see that notation or that announcement, you could just pick up the phone and call Dr. Dean Burns's practice and said, "Hey, I saw that you're going to be a part of this. I'd like to come in and be evaluated for the trial." And then you do everything else from that. Now, what comes with that is you get free surgery. The downside of that is you have got to be a part of every bit of the follow-up because it's really damning to the company if in an FDA trial you lose patients to follow-up. FDA frowns on that, and it can hurt the product's ability to get approved. So that's basically it. We can announce who we're going to work with, and then you can pick up the phone and schedule some time to go see them.
Yeah, makes sense. All right. Here is a question from JJ. He says he's followed the company since the beginning. Thanks, JJ. He asks, he's seen that you cannot put your lens in someone if they have already had a cataract replacement surgery. Will that ever change at any point?
Okay, so that's it's not a technology question. It's an ethical question. So here's the challenge. When you have had prior lens surgery, the body scars down. And when it scars down, it entraps whatever the intraocular lens is that you have in your eye. The doctor who would actually do that surgery has to free up the lens so that you can take it out. You can't just yank it out. I mean, it's like in there. So it's not an Ocumetics issue if the doctor wants to do, it's called an explant. If they want to explant an IOL and implant the Ocumetics, they can actually do that. But it depends on how long the lens has been in, how much scarring has taken place, and how difficult it would be to take that lens out. And if that lens is in to support something else, they may elect not to even do that surgery at all. So the easiest way to find out if that's something that you want to do is to just go get an eye exam, see your ophthalmologist, not an optometrist, but see your ophthalmologist and say, hey, I was thinking about having an explant of this lens and maybe upgrade to a different lens. Is that something that you recommend? And take direction from your ophthalmologist, not an optometrist.
Right. Okay. We got a bit of a long one here, so I'll try to do this as best as I can, but it's kind of along the same lines. This one's from Ken. So he's been an investor since the private placement. Thanks, Ken. He's been waiting years for our lens, but he says he couldn't wait any longer as one of his eyes has cataract. And he ended up having the surgery done on one eye in April. He was hoping to participate in the clinical studies, but wasn't contacted. So now the appointment for his other eye is set for October. So he has a couple questions. One, should he elect to wait and wait for our lens to come to market? And can it work with one eye using the traditional lens while having the Ocumetics lens in the other eye?
Okay, so let me answer the question in reverse order.
Yeah.
So can it work with one eye? That's exactly what we're doing in the trial today. So we're putting Ocumetics in one eye, and we're putting whatever commercially is available in the clinic in the other eye. So that's exactly what our protocol calls for until we get to group 3, where we do binocular summation and we put Ocumetics in both eyes. If I were Ken, I wouldn't wait because if you remember the slide that I showed about the road and the studies, just to get to an approval, we're probably 2030. So we're 4.5 to 5 years out. And there's no way I could even force the agency to speed up because the timeline that I'm using is actually the FDA's timeline. And they don't speed up for anybody. It is what it is. So from a quality of life perspective, Ken, I'm not an ophthalmologist and I'm not giving clinical advice, but personal advice for quality of life, I would go ahead and take advantage of having that surgery done now so that your quality of life is good. Would I love you to have this lens? Absolutely. But, at some point in time, you have to put the patient first. And so quality of life and putting the patient first tells me that you should probably just go ahead and work with your ophthalmologist and have the surgery done. So that's what I would do personally. And I don't know if I mentioned to the group, I had cataract surgery 2 years ago. And 2 years ago, I was the CEO of this company. And 2 years ago, I was having the same internal discussions, should I wait or what? And one eye just got worse than the other to the point where my quality of life suffered. And so I elected to go ahead and have the surgery. And I have now lived through 18 months of all those side effects that I showed earlier. And they are real. And my wife will tell you that, and she doesn't even like to drive at night, but she had to drive because I lost confidence and I couldn't see. Everything was a big glare source to me, and it just bothered me. So I would do the surgery.
Fair point. Makes sense.
Yep.
Another good question here. This is from Jeremy. So he asks, will another trial be required specifically for correcting poor vision, aka without cataract correction being involved?
Let me ask the question again.
So he's asking if another clinical trial will be required for one of our lenses to just correct poor vision rather than like cataract being involved.
Okay. Sean, I'm going to answer the question a little bit different because I'm going to try to rephrase it.
Yeah.
I think I know what's being asked, um, but I need to reverse the question a little bit. Okay. So the word cataract is just a clinical name that we assign to lens replacement surgery. So inside the eye, there's a crystalline lens. It sits in a bag. We have to take a machine and we have to remove that lens and then replace it with something else. Whether we take out a diseased lens, which is really cloudy, or whether we take out a clear lens because the patient just can't see. Let's just say they are 35 years of age, they don't have a cataract, but they have poor vision. They just can't see. So let's just call them a -5 myope. They don't have a cataract, they just can't see. We still have to take the lens out. So the procedure for, we call it a clear lensectomy or clear lens extraction. The procedure to do that on a 35-year-old patient is the same procedure that we would do on a 65-year patient who has a cataract. So we use the same technology, we use the same procedure, we use the same techniques to do both surgeries. So in his case, if he just has a condition, either he's hyperopic, which means that he's farsighted. If he's myopic, he's nearsighted, which means he sees better near than he does in the distance. We still have to take out the lens, so we'll suck it out with the tools that we have, and then we'll replace it with like an Ocumetics lens. If I were a 35-year-old individual who was suffering from either myopia or hyperopia, and my vision was really terrible, this would be a great option for that patient if it were available. That'd be a great option.
Cool.
If it's good for a cataract patient who's older, it's got to be just as good or better for a young patient.
Would that be this lens that we're in trials with now, or would that potentially be like a future lens?
It would be this lens.
Okay.
We have a lot of different lens designs. We won't go into it, and because of insider trading stuff, I can't really talk about them. That will be targeted at different unmet needs. The one that was just described would be handled by this lens that we have today.
Interesting. Okay. Here's a question from John. I can actually answer this one. So he's asking if he can invest now. So yeah, absolutely, John. We're a public company, so we trade on the TSX Venture Exchange. We also trade on the Frankfurt Exchange, and then on the OTC markets. So you can absolutely go purchase our shares tomorrow if you're interested in that. If you're asking about a private placement, we don't have one open at the moment.
You just closed one.
We did, yeah. And yeah. Okay, so the next one here, let me find a good one. This one is from Ibrahim. So he asks, he has very high myopia, -24, and 8 out of 10 visual acuity with scleral lenses. If his retina is healthy, could he be a candidate for the Ocumetics lens?
Wow. Uh, that question actually would be best answered by an ophthalmologist, because so when you're, all right, so let me do it. So I'm gonna sound like I'm talking out of both sides of my mouth. Uh, can we create a lens that could correct that? The short answer is yes. But here's the problem. When you are a high myope, like what you're describing, the other thing that has to be taken into consideration, and you mentioned retina, is with a high myope, there's a high probability and chance that you'll have a retina detachment. And if that occurs, that is like the complication that you don't want to get. But that happens with a high myope. And when you have these high performing lenses like accommodating and bi and trifocals and maybe even extended depth of focus, what it does is it actually amplifies your visual problems. It actually makes it kind of worse, because these lenses are, it's like playing golf. They are like precision lenses, but when they're off, it is an absolute nightmare. So I would not want to be the guy on this this webinar saying, "Yeah, go for it." I want to be the guy saying, "Go talk to your doctor," because the chances of a retinal detachment, you're probably in that 60 to 70 percentile range, and or higher. And you and your doctor would actually have to make a decision on what they would end up doing with these high performance lenses. So that's one of those questions where you really want to point them to getting really good clinical advice. And do yourself a favor, um, go to an ophthalmologist. Optometrists are really good, so I'm not poo-pooing those practices, because I think the world of those guys. But your ophthalmologist is going to have a first row seat to any complication that could come up with a cataract extraction and lens implantation. And you're going to get better insights on, for your eye condition, the length of the eye, the refractive error they're trying to correct, what's going to be best for you. So please go do that.
Well said. Okay, here's a question about the first human. So this is from David. He asks, did you fit the first group of 10 patients into the August 15th surgery day? And how long do you follow them until moving to the second group?
Okay, so we don't discuss number of patients in groups, so I won't answer that part of it, because we have to work with the surgical schedule at the facility. But everybody who goes through the study has to go through the same check-in endpoints, which is 1 month. Excuse me, it's 1 day, 1 week, 1 month, 3 months, 6 months, 9 months. Everybody has to go through that. And so we just reported out in a press release that 1 week out of surgery, the patients are doing really good. And so it's inappropriate for me to report how many patients. What's appropriate is that we don't have any adverse issues. We had no surgical complications. We actually have no problems with the group that we just did, so much so that the hospital and the surgeon are actively trying to get as many patients as they can into the second surgical day. So that speaks volumes of the technology when the whole staff and the surgeon who actually did the work said, oh yeah, we want to do more patients. These patients are doing really well.
Cool. Okay, here's another one. This one's from Chad. So he asks, what fills the space between the lenses? He says, is it gas or saline? And if it's saline, does that address altitude concerns with a gas-filled lens?
Yeah. So the very first technology we had was air filled. And the reason I'm laughing is that was the very first encounter I had with this technology. And so I looked at it a little bit different. I looked at it as a traveler. I'm on and off of airplanes all the time. And one of the cities I frequent is Denver,
Huh.
Colorado. So my question to the designers were, do I lose accommodation if I get in an airplane, and will this lens not work in Denver? And we all started laughing and said, wow, we never really thought about that. So in an airplane, the air gets pressurized. And so when you do the reverse calculation, you don't lose your accommodation because of the pressurization in the airplane. When you are outside, however, that's not the case. So if you go up on a mountain outside, it's not pressurized. So the very first lens we had was air filled, and what we realized was if you went over a certain height, you would actually lose accommodation. So we got away from an air filled lens and we went to a water filled lens. So inside our lens is water versus silicone oil that you find in all the other competitors that we are competing with. And what happens is inside the eye, there's a solution called aqueous. And that's inside your eye today. That's just the normal solution, and we're always producing aqueous. Well, when we implant this lens, it goes in with air in the space, but as soon as the muscle starts working on it, the air gets squeezed out and water comes in to replace where the air was. And so the backside of that question of if you go up in an airplane or climb a mountain, do you lose accommodation? The answer is no. And so we are a water filled, well, I have to use the clinical term because it's not just H2O, it's actually aqueous, which is a bicarbonate type solution. So we are an aqueous filled lens technology, to be clinically correct.
Cool. Okay, here's a good one from David. He says he thinks the lens has three parts to it. So he'd like to hear how the procedure is different from a traditional lens, specifically around the length of the procedure and any additional steps that are a part of the procedure.
Okay, so I'm going to make an assumption as I answer this question that David's been on the website and he's viewed some of the materials that are there, which we need to update because what we did was we took a three-part lens and we made it into a one-part surgery. So let me see if I can walk you through what that is. There's a retainer, an anterior and posterior segment lens encased in one lens. And the surgical procedure is you take the lens and you fold it into a taco. You put it into the lens carrier that actually is a holder that has a straw-like protrusion at the end of it, which is what gets inserted into the incision, and we inject the lens into the eye. So the lens gets injected as one complete complex versus the way it used to be, which was two big segments. It's now one, and it gets injected into the eye. The length of time for surgery is actually the same time as it is for a monofocal lens. So we didn't increase the surgical time. We just increased who actually has to load that lens, the procedure to load it, because you have to load it a certain way. With a monofocal lens, you can flip it upside down and load it. And if it goes in wrong, you just spin it around and you're good. With this lens, you have to load it in the right way, because we don't want you to, once it goes in and we get it properly centered, we don't want you tugging and pulling at it because this lens settles in very nicely because it's big enough to fill the whole space. And we don't want a lot of manipulations once you get it inserted in the eye. So we spend a little bit more time on loading the lens in the carrier and then injecting the lens into the eye so that it seats properly. And that whole technique is called effective lens positioning. So there's a clinical relevant term for that. And our seating, at least with the first group of surgeries we did, that lens settles in really nice and it's very centered, which is what you want. You don't want it optically off one axis versus the other.
Right. Okay, we got some good questions here just about the first in human. So as far as in the first in human study, in the control eye, what lens is going in there? So it's obviously not it's obviously not an accommodating lens. Would it be a multifocal or a single focus lens?
It's a monofocal lens, so it's a single focus lens that's going in the control eye, and then in the target eye is the Ocumetics lens. And so that's for groups 1 and group 2. In group 3, we want to get to binocular summation, so Ocumetics in both eyes.
Okay. And then here's a good follow-up to that from John. So he's asking, obviously, so the patients have different lenses in each eye. What happens after? Will they be able to have the control lens replaced, or how does that work?
Yeah, so if we get down the pathway and the patient says, "Hey, I like my vision with the Ocumetics lens," what we can do is it's called match surgery. We can figure out what that control lens is, and we can match it, but we can't do it until we do the binocular summation group, because we need to understand how these two lenses are going to perform.
Right. Okay. Got a lot of questions here, so my
I'll keep
apologies
going.
if we don't get to everyone.
Yeah, I'm good if you just keep going.
Okay, sounds good. This one is just regarding a potential future financing. So, if we're trying to raise 25 million, what would that financing look like? Would it be a debenture, private placement? And then would there be any future plans to uplist on the NASDAQ?
Yeah, so let me answer that one, Sean. It would be a private placement, is what we would want to do. And right now, I'm interested in talking to anybody who wants to be a lead investor on that when we actually open it up. Um, we have had several conversations. In fact, I just had one last week about uplisting on the NASDAQ. What I have to do to get to the NASDAQ is I have to do, it's called a cross-border agreement. And it's where TSX and the SEC allow us to trade on NASDAQ. And so I'm working through the mechanics of that, which is both legal and it's financial. So stay tuned for more of that. And yes, we are looking to uplist. And one other thing, Sean.
Yeah.
which is really important. One of the things that we had to do, which actually is historical and it happened last week as well, is we went from a market cap of 38 million to basically 120 million with all the news that we put out. The market was very, very, very friendly to us because our stock went from basically we did that private placement at 35 cents. So we went all the way up to $2 and we came back down, settled somewhere between 38, excuse me, a buck 38 and a 159. So we're playing in that area right now. But what that did was that changed our market cap to well over 120 million, which then gave us the ability to uplist on NASDAQ.
Very interesting. Cool. Well, exciting times, obviously.
Yep.
Next question here. This one's from David. He asks, for those who've had laser eye surgery, is the Ocumetics lens still an option, or would there be complications with that?
No. It's a good thing that I created the whole refractive offering at Alcon, so I know a lot about laser surgery. When you do laser surgery, you only work on the curvature of the front part of the eye. So you change the shape of the cornea and you actually make that shape better than it was when you were born. The problem is the middle part of the eye, the lens is changing. So when you have cataract surgery and you put in one of these high performing lenses, your vision is going to be incredible. So you would absolutely be one of the primary candidates for this type of surgery.
Very cool. Okay, this one's from David. He's just asking about the timeline to a potential FDA approval. So let's say the first in human take about 12 to 18 months. What is the timeline there until we get to a potential FDA approval?
So in my slide, I showed that to get through the multi-center clinical trial, it actually takes 36 months. So it's a 3-year process. And it's a 3-phase study, so it has individual groups as well. And then you take 36 and you add 18 to that, which is where we are with the first in human, which is why we won't have an approval until 2030.
Yeah.
So that's where the whole timeline, and there are a whole lot of things that actually have to happen in order to meet that timeline. But that's the most conservative timeline I can give you for US commercialization. Now, one of the things that we tend to look at is what can we do in other regulatory domains to get this technology out? So what can we do outside the US? The process to get the technology commercially viable and available is called CE marking. There are regulatory jurisdictions around the world that are very friendly to products like this. The key thing is you have to have data to show how well or how poorly the lens is performing. So in my slide, I showed you that the FDA study is a performance study. So proof of performance is what the FDA study is. So the first phase, which is usually anywhere from 50 to 100 patients, if your data looks really good in that first phase, you can actually use that data and go around the world to see if you could get your product CE marked. And that's one of our strategies. We want to look at early commercial options using the CE mark process and the data that comes out of at least that first group of FDA patients. And so once we get to that point, we'll start looking at a commercial model for the organization, which will be revenue driven. And, I'll have to look at, how we source the product. So right now, the product is going to be made in Erlangen, Germany. But then I have to figure out how to get it from Erlangen, Germany around the world. And so I have to begin looking at distribution opportunities for the lens. So we still have a lot of work ahead of us, but this is nothing that I haven't done in the past. And I'm looking forward to doing it.
Exciting stuff. Okay, a couple more questions here. This one's from Terry. Is the recovery timeline for the lens similar to or the same as current IOLs?
The same.
And what is the timeline for recovery?
Yeah, so a patient doesn't really receive it, what we call best vision, until about 3 months. But what happens after 1 month, the vision just gets better and better because the thing they're not dealing with is healing. So the eye, following surgery, has been traumatized with instruments in and out and things that have happened. So we call it quietness. We need to let the eye settle down and become quiet. That usually takes about a month. So it's like any other surgery, whether it's external to the body or laparoscopically internal. As soon as you make an incision on the body has to heal. Same thing happens in the eye, and it usually takes anywhere from 2, 3, maybe 4 weeks for that healing to occur. During that time, the eye quiets down, and the patient then begins to have their best vision. So depth of focus is really good. Colors are vibrant. The detail in things is unbelievable. And so they start challenging themselves to read everything they could see. On the highway, you can see the different signs. You go somewhere in a restaurant, you want to be able to read the menu without worrying about reaching for your cheaters and having aid there. So uh, uh, that happens after 1 month. By the time they get to 3 months, man, they are seeing like you wouldn't believe. And that's their happiest. And that's when we start, we call it 2020 happy. That's when we start asking them how well we did. That's when you take the survey.
There we go. Okay, that's a decent follow-up to that. So do we know how much accommodations, or sorry, how much accommodation the patients who've received the lens are achieving?
We do, but I can't tell you.
Fair enough. Another question here, just about the about how long the lens lasts. So, is the lens built to last a lifetime?
It lasts forever. This will be the last ocular surgery you'll have unless you have a problem with your retina or you have an accident.
Right. Okay.
Or maybe glaucoma, something like that.
Right. Okay. A lot of these are just doubling up now.
Yeah, take your time. I've got time today.
Okay. I think you kind of said obviously we can't mention how much the lens costs.
Yeah, but
But how?
I'll comment on that.
Yeah.
So we can't talk about uh, what that. So there are two. Lot. Let me do just one part of education. There are two costs associated with this type of technology. There's the cost from the manufacturer to the provider, and it could be a hospital, freestanding ASC, or a doctor's office. That's one charge. There's a second charge from the provider to the patient. Most of the time when we get that question, it's about the patient cost. How much is this thing going to cost me to get? So in today's dollars, and I'll use US dollars, to get one of these high performing premium lenses that I showed with, the greens and yellows, today's dollars, it costs $2,000 per lens. That's today's dollars. And that price will vary depending on where you are in the world. So there are parts of the world where it's more, it could be $3,000, $4,000 a lens. And then there are parts of the world where it's cheaper. It could be $1,500 a lens. But on average, it's somewhere around $2,000 a lens. So if you're trying to figure out, can I afford that lens? Most of us will do what's called price parity. So we won't gouge, at least Ocumetics won't. Under my watch, we're not gouging on this technology. I would rather take a little less and make it available for everybody than to really jack up the price and only have 10% of the market able to afford it. Because that doesn't make sense to me.
Right.
So there you have it.
Okay, good stuff. Just a couple questions here, kind of about, exit strategy. So this question is from Derek. He asks, do you see Ocumetics staying independent until full FDA approval, or would you eventually think we would sell the technology?
Um, that is a strategy that we talk about all the time in our board meetings, as well as the leadership group of Ocumetics. And the company is actually split on whether or not we stay independent and go our way, or whether we get absorbed through an M&A deal from one of the strategics. My personal favorite is kind of a combination of both, because I have got a fantastic scientist that I just want to give him a mad lab and just let him just continue to develop, because the guy is brilliant and he's not finished. And I just want to just give, I call it his playground. I just want to give him a playground and just let him have fun. So there are a couple ways that you can actually do that. One way is just keep the company and sell the technology. Another way is to sell the company and the technology, but keep the patents. So we just keep the patents. Another way that's out there is we sell the whole thing. The problem with that is once we sell to a strategic, we actually lose our ability to influence, unless in part of that deal, you make sure that the research part of it stays Ocumetics. Because if you think about it, Sean, Ocumetics for 18 years was just a research company. It's only been the last 3 years that we took something that was designed. When I came into this business, we were on lens version number 3. And now we're on lens version 12.5. We have optimized our way to where we are in first in human. And we've done that in less than 2 years, 18 months basically, versus where the company has been for the last 18 years. So we know that we can design lenses. We know that we can manufacture it now. And it's just a matter of what type of deal works for the company. And so we are really all over the map right now as to what makes sense. I've got my favorites, but I won't share them in an open forum. And, Dr. Webb, who is the designer of the lens, he's got his favorite. The board, they all have their favorite. But what it's going to come down to is we'll make that decision depending on what deals are put in front of us. Right now, we're just making sure that we make the best possible product that patients can be proud of and we can be happy with, that effectively keep them safe and allow them to see really well. And then whatever that deal looks like, we will evaluate it. What I do know is I've got about 3,000 shareholders.
Yeah,
It will go in front of the shareholders, and the shareholders will have a voice as to what we do.
good point.
This will not just be a Dean Burns or Dr. Garth Webb decision. It will be a shareholder decision, and we'll do what's right by the company.
Of course. Okay, here's a question just about the last financing and a potential future financing. I don't know if we can exactly answer this, but I believe it was Numis who ran the last private placement. Gary's asking if it would be the same company that would do a potential next private placement.
So the so Gary, we have established new relationships for our raise. I'm not in a position to say who that is. We are bound by the TSXV guidelines that once we decide to do a private placement and we ink a contract, we actually have to press release that. And so I'm not going to get over my skis on this question. You'll see who we're working with at the appropriate time.
Fair enough. Okay. Okay, so we're getting quite a few questions just about the different lenses that might be used for like an under 45
Yeah.
person. So what would be the main differences in the lenses?
Well, so I didn't want to talk technology and geek out on the audience here. There's certain things about a 45-year-old or younger than 45-year-old eye versus an older eye that we have to take into consideration. One of those things is how well or how poorly does the pupil actually work. The pupil is that little thing. It's the black hole in the middle of the iris. So the iris expands and opens up when you're in dim light situations. So you're at a restaurant, a concert, a play. Your pupil gets really big, which allows you to see. You get out of your car at nighttime and you don't have light. Your pupil dilates really big so that you can take in as much light as possible. So with a younger patient, they typically have really large pupils. So functionally, the dilation of the eye is a little bit different. The other thing is when you're younger, you tend to want, your eye wants more accommodative range. So right now, the accommodative range that we put in the Ocumetics lens is 3.5. With a younger patient, that younger patient's eye may want 4, 5, or 6 diopters, and that's amplitude of accommodation. And so we need to really study whether or not we want to change the curves of our lenses to actually allow for more accommodative amplitude. Right now we have 3.5. The lens was designed to do 14, but you can't put 14 in an eye. The patient would just go stare crazy with that type of vision. So we backed it down to 3.5 because when you start looking at the cheaters that people put on, once you get to about a +3, you're kind of ready to go talk to your ophthalmologist about having surgery anyway. So we're just using the range of what patients would need if they had to go get cheaters or prescription glasses to see. If you are a younger patient, you may want to have more accommodative amplitude. Now, this is different from the refraction. And so I've gotten a lot of hate mail saying that this lens was crappy because it only has 3 diopters of accommodation. But what they fail to realize is I'm just talking accommodation. I'm not talking the dioptric range of a set of lenses, which would go from probably probably from a 19 up to 32. That's a full range of lenses. Uh, so that's not what I'm talking about. I'm talking about accommodative amplitude. And so that's what we are studying right now to see if there's truly a difference. If there is, do we have to make 2 lenses, or can we optimize our lens to address both groups? Which is a great problem to have, by the way.
Right. Okay, here's a decent follow-up to that. This is from Cedric. So he says, do you envision the Ocumetics lens eventually becoming the standard procedure for all types of vision correction? So not just cataract patients.
So I have this impulse. The reason I'm pausing, because I want to say yes. I just want to say yes. But because I'm such a conservative person, I'm trying to think about inclusion and exclusion based on that question. And so I would answer it this way. For all the patients that would qualify for a lens extraction, whether it's a clear lens or a cataract, I would love this to be the lens of choice for all those patients. But if you are a patient that also suffers from uh, anything with your retina, anything in the angle with pressure, any kind of corneal situation, I don't really want this to be the lens for that. And the reason is these high performance lenses amplify those types of problems. And I believe those patients would not be happy. But if the cornea is good, you don't have a pressure issue, and the retina is really good, you don't have bleeding or AMD, which is a different kind of disease. If you don't have any of those problems, absolutely, I want this to be the lens of choice for everything.
Love it. And then even looking further in the future than that, so thinking of, what's the potential just for this technology? Like, will a version of the lens ever be able to, give somebody superhuman vision, let's say?
Okay. We used to call Eagle Vision superhuman vision. All right. So the eagle has the best vision of all the birds. With the exception, I would argue, of an owl, because the owl doesn't see well in the day, but it's the best visual bird at night. And it's because of how big their pupils open up, so they can see a lot. Eagle vision, we used to say when I did refractive surgery, if you could get a patient to 20/12.5, so normal, acceptable, great vision is 20/20. Then you step it down to 20/15, and then you step it down even further to either 20/12.5 or 20/10. So when you get to 20/10, you're actually getting into eagle vision uh, areas. And if we had that kind of vision, the kind of dust that looks like snow that you can see in a room sometime with the sunlight coming in, imagine seeing that all the time.
That sounds awful.
Yeah, you wouldn't like it. So there's certain things about how we filter light and how we see. If a patient can get to 20/15, that is really, in my opinion, as good as they should get. The Top Gun pilots that fly airplanes are the guys that have 2015 type vision. And what they can do is they can see a black small object up against a cloudy sky, uh, or up against a bunch of clouds, so much so that they can target whatever that thing is and shoot it down. Those are the guys that really, really, really enjoy 2015 type vision. Now, in my case, with my surgery, I am 2015 in my right eye and 2020 in my left eye. So on my chart, it says 2020 plus letters, which means on the 2015 line, I was able to get, if there were 5 letters, I probably got 2.5 letters because one was a guess. So I got 2, but one was a guess, and they put it down as 2020 plus 3. But my vision is really good. The reason I wear glasses now is I have a muscle issue in this eye that I've had since I was a baby, or since I was a young tot, and I refuse to have surgery for it. So these are non-prescription glasses. They have prisms in it so that I can see everything horizontally in the same plane. If I don't wear these, I have one line if I'm reading up here and one line of reading down here. So I have to bring them up, and they do it with prisms in the glasses.
Okay, getting to the end of questions here. This one's from Cedric. So he asks, you mentioned that the initial go-to-market focus is on patients 65 and over undergoing cataract surgery. Can you just elaborate on why the target isn't broader, such as younger people with poor vision?
Well, Cedric, I don't know when you came in on the discussion. We want to penetrate the target audience of cataract and over because that's what our FDA indications are. When you get into that other group, that's what we refer to as a refractive target. And it could trigger another FDA study, which I don't want to do, or we could allow the doctors to make that choice as to whether or not they want to do a clear lens procedure on a younger patient using this technology. I would rather give the doctors the tool and let them make the decision. So the penetration into both areas will actually naturally happen. What I want to be very focused on is we're going through the FDA process for cataract indication, which also comes with an age stipulation. So if you look at our protocol, it says, patients that are 65 years of age with a cloudy lens would qualify for this lens. And we do know that that segment represents about $1.2 billion worth of commercial activity. So we could be the dominant player in that and then get the halo effect from that next group. And so when we start building our business models on this lens, we could easily start looking at $750 million worth of commercial activity with just one product, not to mention all the other things that we're looking at. So I think we could build a pretty good business off of $750 million worth of commercial activity.
Cool. And I mean, this next question is a good segue from that. So, can you speak at all to the financial outlook for the company in terms of maybe revenue targets or a share price target, assuming FDA approval?
Yeah, so I won't go down the share rabbit hole because there are a lot of things that can affect that. But we did put some revenue projections in place. And those revenue projections are based on share acquisition of the current market and then market expansion opportunities that go just with the lens area. So from an acquisition perspective, we expect within 3 years to be at a minimum a 40% share player, maybe even up to 55% of the $1.2 billion area. So in raw numbers, if I did the math, that just means that we're going to be $500 million as a company. All right. And then we would bleed into that next group, which would probably give us another 200 million. So we could easily be very close to $1 billion organization over a 5-year period of time. Because I can tell you, this is the Holy Grail. This is the product that people have been waiting for. And it would be my bet, and I would actually bet on this particular horse, that there's going to be a lot of cannibalization that takes place from monofocal and either bifocal or trifocal technology if these lenses prove to give full range vision without side effects. And if we either price parity or figure out a pricing scheme that actually makes sense, and it's not a barrier of entry for patients, this is going to be the dominant player. And I'm looking at all of these things to make sure that Ocumetics is the dominant player in this particular space. Now, having said that, our shares trading right now, $1.39, and we actually have the potential of 3 or 4xing that number. But a lot of that's going to depend on how well we communicate with the market, all the market-based activities that we're already planning to do, the communication that we plan to roll out. We have to be very careful because we're now on the FDA's radar. So we can't do the shoulda, coulda, woulda dance on this one by promoting things that we're not able to study. So if we say this is the best thing since sliced bread, then we have to do a study with this lens with sliced bread to prove that. So if we say that we're better than the competition, they're going to say which one. And if we name one, they're going to say, now you have to study your lens against them. So I refer to that as the bigger, better, best. We don't want to go down that pathway. I want every technology to be able to communicate the value proposition of what their lens is capable of doing. I want to be able to do that. I want to talk specifically about my technology. All the airtime that's there is going to be on Ocumetics and how we're doing in our clinicals. And I'm going to let the market decide who's the best. What our doctors will do is everybody will get a trial to see if the lens does work. So every doctor out there that does cataract or clear lens extraction will basically try all these technologies, and then they'll decide which one they like. What I want to do is I want to take trial to usage to adoption. And part of that process is called crossing the chasm, looking at, how do you go from early adopters and innovators who will stand out in the middle of a snowstorm to get the next available iPhone that's available because the color changed. I don't want that group to be my market. I want the next group that says, hey, I'm going to wait until it becomes readily available or until I really need it. That's the group I want, because that's the group where you get adoption and you get loyalty. And that's the group I'm going to be communicating to once this lens becomes better. And those of you who don't know my background with Alcon, I was known as the Dragon Slayer. So not only do I know how to talk a really good game about the value proposition of my technologies, I also know how to do opposition messaging. against competition. And so I've gotten a lot of FDA cease and desist type letters because the competition just got really angry with me. And I didn't even stop because everything I said was the truth. So I have a high ethical and integrity standard. So I'm not going to lie, but I will expose your weaknesses. So my goal is to take over the market and be the dominant player in this space. And nobody's going to lay down and just give it to me. I'm going to have to fight for everything we get.
Great answer. Great answer. So I think that was the perfect question to end things off on. Nice big picture response there. So I'm just going to add a couple things. I know Gene had a question here, just if there would be a transcript of the meeting. So Gene, you'll be able to go rewatch this webinar on our YouTube channel. Should be posted by tomorrow. There might have been a few questions trickling in at the end there, so I apologize. We didn't get to your question. You can always go to our website, ocumetics.com, and feel free to contact us, send us a message. We'd be happy to answer any questions you guys have. And then, of course, there will be more webinars coming up. So we hope to see you all there. This has been, I think, our biggest webinar yet. So appreciate you all joining us. And with that, I'll just leave things to Dean to close things out.
Sean, I'm just going to say thank you to everyone that's been a part of this journey up to this particular point in time. And if you have not been with us long, thanks for just joining us on the next phase of this ride. We truly appreciate you guys sticking with us. We appreciate the fact that you trust us. We appreciate the fact that you're willing to invest in us. I've got a long-standing reputation in this business. And so my word speaks for itself. My experience level is extremely good. And I actually came out of retirement to actually take the helm as president and CEO of Ocumetics. So it's not about me, it's about my people. It's not about my people, it's actually about you guys, because we're a research company trying to figure out how to commercialize what we think is the best IOL for patients that want full range vision. And we're on the next part of this journey. So the second leg of this journey is getting all the way through our clinicals. And then once we finish that, we'll be on the third leg, which is commercialization. So thank you so much for sticking with us. Thank you so much for being a part of the first phase of this journey. And thank you for giving me the opportunity just to share some thoughts with you. We look forward to you coming back on the next one. With that, I'll say goodnight.
All right. Thanks, Dean. Thanks, everybody. See ya.